Good evening, everyone. Welcome to the Aspen Institute. Are you ready for the Ready, Set, Launch publication discussion? I hope everyone is ready. My name is Peggy Clark. I'm Vice President at the Aspen Institute. I'm delighted to welcome you here this evening. Please make yourselves at home. We're coming to the end of the day, so please help yourself to the wine and the cheese and the appetizers. In Washington, partnership is the name of the game. And in Washington, the relationships we form here will see us through any kind of administration that comes before us. And together we can really achieve a lot together if we understand each other and work together. And as some of you may know, there's a fantastic part of USAID which really does partnership in a very real way. And it's the Center for Accelerating Impact and Innovation, Wendy Taylor and David Milestone and their partners. Since we met them several years ago, have distinguished the way that USAID really pushes the envelope on a number of key issues, which I think most of you know in this room today. So I'm delighted to welcome you to the launch of their newest publication in their Ideas to Impact series. Many of you may have been here with us, maybe it was about 2 years ago, when we launched the first publication. But I really just want to take a moment for us to think. It was just 5 years ago when this center was founded, and it started very small. Wendy Taylor founded it. She herself came from doing a number of interesting things, founded BioVentures for global health, Malaria No More, a number of things. But she took this challenge of creating this part of USAID that would really approach global health in a different way. And I think most of you would say that what they've been able to achieve in terms of the Zika challenge, the Ebola challenge, the maternal newborn health challenge, that this center has been small but mighty in the way that it's approached these efforts. And so this report is no exception. It is blessedly practical. We use words like going to scale. We use words like addressing delivery challenges all the time in this town. But what do we really mean by that? How do we really unpack those things? How do we really give our partners and ourselves the ability to really achieve scale in a significant way? And so the center has been able to look at this in a very different way. So they've really broke the mold and how USAID works, particularly with the private sector. And I think many of you would recognize that they have showed us the way to partnerships in a way that I hope we will be able to continue for a long time to come. So this is a time when victories in global health are many. We've reduced child mortality in half in the last 2 decades. We've moved the needle on maternal mortality. Yet, most of us, if we're really honest, would admit that many of the most critical life-saving technologies are not within the reach of countries that are the highest disease burden countries or communities that need them the most. There is a huge distance between the idea of a life-saving technology and its actual launch and effective implementation on the ground. And so that moment, that place, and this report refers to it as a pivot point, when you move from the discovery of an amazing product or technology into how you really make it happen on the ground. And so what I love about this report, and David and Wendy always tease me about this, but it really is where the rubber hits the road. And they really mean it. What is the rubber? What is the road? What do the partners look like? What needs to be done? And this report tells it in terms of stories. We're going to hear from our partners in a number of countries that have been a part of this particular approach. And we all will learn from the ability to not just say things like partner or say things like scale, but to really think about what are the steps involved, who are the stakeholders, what are the activities. So it's always an honor for me to do anything with the Center for Accelerating Innovation and Impact. Wendy Taylor has become a very, very dear friend. I don't know what we're going to do without her, except that David Milestone will take her place for a while, who is an exceptional person. But from the perspective of Aspen, we really just want to say how really honored we are to have walked the journey with you on a number of your initiatives. It's very important for us all to support each other in the next years ahead in terms of our global health challenges. And Wendy Taylor exemplifies true leadership in USAID. So it's been an honor to work with you, Wendy. This is a really great report. So those of you who haven't had a chance to really dive into it yet, I think you'll find that it is really practical and useful and will make a real difference. So Wendy, over to you. Thanks.
Wow, very nice. Thank you, Peggy. That was extremely nice. And thank you for all of those words. Thank you for hosting us once again. Thank you for being a dear friend to me and to our whole team. And for being a fellow catalyst and disruptor, because we know how important those are in this global health space where we continue to try to do very, very hard things. And we need a lot of catalysts and disruptors out there. So really appreciate it. I just want to even start off by doing some big thanks to our team. And Peggy mentioned David Milestone, who has been a key player on this particular report, and also even in helping get our center started up. But also Nikki Tyler, who is here somewhere, maybe behind the big pillar. Oh, there you are. And the team at Dahlberg, who is also here, and really were instrumental in helping put this together. And I think you'll hear some more thank yous there. Also, Denise Joseph and Rachel Fowler, who helped make this event happen. And then thanks to all of you for joining us today. And we hope to have a pretty dynamic panel that also engages all of you. And Aspen very graciously actually gave some wine before the event started. So hopefully that will make things all the more lively. But in global health, and I think many of you actually come out of global health, so you all are kind of acutely aware that in global health we have already achieved tremendous progress over the last several decades in health, and we are seeing child mortality declining. We are seeing, and finally at a place where we can start talking about an AIDS-free generation. And we've made great progress, and that is because we have been able to get many of the innovations that have already been invested in for decades and starting to get them into the hands of those that need them. But we have so much more work to do. And our center was really founded on this idea that we have many life-saving tools at our fingertips, yet so many of them are not getting to those that actually need them. Yet business is, when we look at business is so well optimized to be able to, the second they have a product, they get out the door, launch that product, and they're looking for peak market penetration. No, that doesn't work. How about this one? See, Janice told me that it'd be easy, and the arrows look simple. Okay, well, it's not correct. Yeah, that didn't work either, but that's okay. I don't even need that slide yet. But anyway, so you can advance it. Well, you can. But really, how do we bring in that business, and this is now the music soundtrack, how do we bring in that business and marketplace thinking, that business rigor from the private sector to how we introduce and scale innovations? And that really was what the center was all about. So we were looking at and really looking at how we can continue this progress. And we have three key areas where our team is working. And one is continuing to stay ahead of the curve. How do we capture what are the state-of-the-art practices from the private sector, from sort of deep experience within global health, and make sure that we are applying that for greatest impact and adopting it on a regular basis. We also look to keep innovation high on the agenda and continue to invest in game-changing innovations. And we have a laser focus on scale. So we're going to talk today about really that first piece of this, which is how can we continue to stay ahead of the curve and keep even pushing that edge of the envelope further, and so part of this is bringing in those private sector practices and bringing in that shared learning. And one of the lessons we've learned is that we know that innovations that don't plan early, that don't bring in that planning for scale in to the very beginning of product development, often will have challenges scaling later on. And the success goes back to the choices you're making very early. You need to know your end customer, and you need to understand the environment in which you're going to be working. You need to know the market. You need to know how you'll get your product to those that need it. And all of those pieces should be built into the target product profile from the very beginning. And so that piece is really important. But we also know that operating in these markets carries a whole host of challenges. Many of these markets have inefficiencies. And so all the best planning for introduction and scale sometimes is not enough. And we need to continue to have tools where we can address those market inefficiencies, whether through market shaping, whether we can look to use innovative financing in creative ways. And so we also, both of those are necessary to think about how we can continue to shift those curves. And you're missing some of these curves, but we've shown them many, many times. They're even in your book in here. You can flip open to the front end. Is how do we avoid late introduction and slow uptake? We need to be able to shift those curves to the left so that we can start getting products to those that need them much faster. And then finally, we also know how important it is to get launch right, and that's really where we're going to spend some time today. And it was really interesting. We saw, and we talked about this actually when we launched the Intro Scale-Up Guide, and there were a couple of studies, one of which came from McKinsey, that showed that products that, and this is kind of global products, but products that have a kind of slow start at launch often have a really hard time catching up. So launching well is really, really important. And there's about a 6-month window to try to course correct and maybe get back on track. But if you don't launch well and launch successfully, you can have real problems. So that's one of these pieces we're trying to bring back into the process here, and how best to think about that so that we are launching global health products well. So just and
start all over again, Wendy. I'm sure we're going to get it right.
oh, actually, mine aren't that important, but I might have to stall because Dave needs the slides for his piece. So anyway.
You have to sing and dance.
Yeah, right. I'll play my daughter's video. But anyway, so really, one of the things that we've tried to do is capture all of these learnings into very practical, pragmatic, useful tools that can amplify our impact. And so we today we're launching what is really the third in our Idea to Impact series. And the first, as Peggy mentioned, was the Idea to Impact itself. A better launch, really trying to think about how to bring in sort of planning for delivery really at the very beginning and throughout the product development process. At SOCAP earlier this year, we launched our Pathways to Scale guide, and that was really thinking about, for social entrepreneurs in particular, and innovations that are still sitting in universities, how do you actually think about the right business models for scaling and making those choices of do I license off my technology, or do I take it forward on my own and start my own startup, and how do you actually do that? And so there's some great insights in there. And then the third piece is really this Ready, Set, Launch guide, and which is a country level startup guide. So I'm going to.
Do you want to introduce the panel while this is getting?
Oh, sure. I can do that. We're innovative. We can adapt on the fly. But I'm really excited to be able to bring this guide to all of you, and we're going to try to get into the meat of it and some of the learnings. And what we're going to do is really try to bring it to life a bit with this panel that we have, and we'll bring them up in a minute. But in the interim, let me tell you who we have here, so that when we go into the panel, we'll go right into it. But we have 4 panelists. We have Nicole Leeds, who is the Senior Emerging Market Development Specialist from Medtronic. So Nicole is over here. waving to you all. We have Lena Syed, who is Vice President of Market Strategy from Gradian Health Systems. And that is a change, I think, from on your sheet, but Lena is standing in for a colleague who who couldn't be here today. We have Kate Schroder, who is the Senior Director of Essential Medicines Initiative from CHI, Clinton Health Access Initiative. There's Kate. And then we have Olayinka, Umar-Farouk. How did I do? Did I do that? And she's the Senior Newborn Health Specialist from USAID's flagship Maternal Child Survival Program in Nigeria. So we're going to have a great discussion. I think we have our slides working. So what I'm going to do now is hand this over to Dave, who's going to walk through a little bit of the meat of our guide before we go into our panel.
Thank goodness the slides are back, because I would not have been able to wing it. That's not my forte. Skipping over what Wendy talked about. And we were actually here 2 years ago, and I'm so thankful that it was around that time that we got to know Peggy, who I think demonstrated a little bit her sense of humor. We didn't get to see it in spades today, but it's one of the reasons hopefully you'll get to know her and see how funny she can be. And in fact, those of us who do know her refer to her as Chuckles, Peggy Chuckles Clark. So, no, seriously, thank you, Peggy, and the entire Aspen Global Health and Development team, especially Katie and Janice, have not just been great partners in the AMP Health program and thought leaders otherwise in the work that we do, but have also been tremendous friends. You guys are the best. We're so thankful for all of you guys. So I'm here today to talk about the newest publication, Ready, Set, Launch, that was led by our partners at Dahlberg Consultants Group and Dahlberg Design Impact Group, which is their human-centered design firm, who partnered with our team, which was led by Nikki Tyler, who I'm lucky to be able to work with every day, who did a tremendous job on this. And it's really meant to take these best practices from the private sector, so from med device companies, pharmaceutical companies like Novartis, GSK, BD, Medtronic, who we have on the panel today, and blend that with decades of global health expertise and experience, and bring those together in a way that's, as Peggy mentioned, very practical. And we have sort of three target audiences for this. One, innovators who we often work with through programs like Saving Lives at Birth, who are often very steeped in the technical expertise of their product, but don't often have the expertise to think about country selection and launch scale-up planning. The second piece are implementers, so our implementing partners who we have here in the room today, but also donors who support and fund these to have a better perspective on actually what it takes to turn talk of scale into actual scale. And then this is really meant to be both strategic, so we've outlined a framework and learned from a lot of the work that's been done in sort of scale-up planning from a strategic level, but really spent the majority of the time trying to make this practical and tangible and useful for those who were doing this work. So the guide really has two components. One is, which we have copies of here today, which is a collection of a framework, but also highlights key questions, outputs, illustrative exercises, and is complemented with vignettes and case studies to bring some of these lessons to life. And then most importantly is this toolkit, which are editable tools and templates that are also filled in with actual work that we've done with Olayinka and Chai in Nigeria on the scale up of a low-cost antiseptic. So you can see actually these tools in practice, and then we've also created tools that you can edit and use yourself. The framework is set into three main pieces. One, selecting a geography, so prioritizing, but making sure that you're using all the sort of analysis that you can to select the right geography, but also making sure that your product is appropriate for that given geography. Building a strategy, so asking and answering the key questions and doing the analysis to understand what are the major opportunities to leverage in a given country, but also what are the biggest barriers and what are the interventions you need to overcome those barriers. And then third, this is, as Peggy likes to say, where the rubber meets the road, is turning that strategy into an actual costed implementation plan that sets targets, creates accountability, and moves this idea into action. We've also been careful to align this with sort of guiding principles. The first Peggy talked to as well, which is leadership alongside partnership. All of the successful launches that we've seen have had a core leader who's been held accountable, but also has the authority to make decisions and ultimately drive progress. But it's so important, especially in these countries, to work with partners, especially the Ministry of Health when you can. And so it's finding this right balance between leadership and partnership. This piece of integration, none of these innovations, whether it be a drug, device, diagnostic, or even delivery model, can stand alone. It needs to be embedded within the health system in which you're trying to work. Reevaluation and iteration. Scale is not a linear process, and so we'll hear a little bit about some failures today on the panel. And so it's recognizing when things aren't working and being able to pivot and reevaluate and fail forward. And finally, sustainability. All of these products need to have a clear definition of how they're either going to be financed through public markets or generate revenue through private markets. And that needs to be clear from the beginning. And I think we have a diverse panel that can reflect some of those learnings. And then finally, all of these frameworks and tools are geared around what we call the 5 components of scale-up, which is market and user understanding, the supply side pieces, manufacturing and distribution, clinical evidence and regulatory, policy, advocacy, and financing, and ultimately this idea of coordination and this piece around leadership. The guide, again, is outlined through sort of key questions that identifies key outputs and activities. It's complemented by vignettes, but also longer case studies at the end of the guide that I think illustrate this whole process from the beginning to the end. And then also, most importantly, it includes tips from the experts, folks who are doing this or who have done it, who can contextualize all of the work that we're trying to lay out in here through real-world advice. We've also, as I mentioned, what I think is in many ways, the most important part of this work is this collection of tools that can help move these ideas into action. And so today we have a set of 15 tools in a toolkit that you can download. We've also included a composite of all of this work. It's not meant to replace the activities and tools laid out in the guide, but is meant to be a way to allow you to brainstorm and use this as a way to capture progress over time, and that's the country launch canvas. And so we hope you can all check that out. It's included in the hard copies that are here today, but you can also download it. So with that, I'm going to hand it off to the panel, who can head on up, and Wendy Taylor, who is the person responsible for the vision behind this Idea to Impact series, and has informed it not only with her expertise and intellectual input into all of this, but more importantly by her example of always being on the cutting edge of thinking, but always forcing us to turn that talking and ideas into action on behalf of those that we're doing this work. So I'll hand it over to Wendy, and Wendy, take it away.
Okay, thank you, Dave. That was great. So we're going to jump right in, and we've done our introductions. So what I'm going to ask each of our panelists to do is just give kind of the 30 to 60 seconds of add a little bit more color to your title and tell us how you're connected to our conversation today. 30 to 60 seconds, so super fast.
Okay, I'm Olayinka Umar-Farouk. I work for USAID, NCSP Maternal and Child Survival Program in Nigeria as a senior newborn health specialist. I'm working to support the Federal Ministry of Health with scaling up health interventions, and we started with Geo.
I'm Lena Syed. I'm with Gradian Health Systems. I've been with Gradian for 4 years, managing their in-country distribution strategies. So we're currently in 25 countries, so I work really closely with a lot of the distributors and in-country partners in the countries we work on.
Good afternoon. I'm Kate Schroder with the Clinton Health Access Initiative. I head up our global team that works on diarrhea and pneumonia scale-up across 5 countries: India, Nigeria, Kenya, Ethiopia, and Uganda. And prior to that, I worked on a pediatric HIV program with CHIDE. I've been there about 10 years now.
And I'm Nicole Leeds. I'm with Medtronic. We are the world's largest medical device company. You probably know us if you have a pacemaker or you're a type 1 diabetic. So I'm on our emerging markets strategy team, and what brings me to this panel is that I previously worked on a social business that Medtronic is running in India called the Shruti program, which addresses chronic ear infections in low-income populations in India.
Excellent. All right, so I'm going to start with Kate and Nicole. So why is it so darn hard to actually introduce and scale innovations in the developing world? And we can talk specifically in global health. What makes it so hard, and why does it take so long? Why are we delayed getting there? So give us a little color to that.
Sure, I'm happy to kick it off. So, I think it's been interesting, my experience. I've worked on the HIV side and now more recently on zinc and ORS with childhood diarrhea. And I think there's a couple factors that really influence the speed. The number one reason it's slow in global health is that information is really fragmented. There's lack of transparency. It's not like when a company introduces a product in a developed market, there's a lot of information about what the demand is, and the projections on that are very clear. Whereas in these countries, it's incredibly dispersed. And I think when I think back on my experience, I think there's three things that really influence what that speed is. And the first one is, do you have clarity on global consensus on this is the superior recommended product? So everybody, and particularly if it's a medicine, if the WHO recommends it, then countries in lockstep work around that. Devices are more tricky because there isn't, as I'm sure Nicole knows, there isn't that unifying consensus. But that's going to be your first factor influencing speed. The second is how consolidated are the buyers? So in something like ARVs, where you've got PEPFAR, Global Fund, and usually the country governments are your three main buyers in country, or with vaccines, Gavi, and your country. And that makes it so much easier to control scale up. And that's why you saw those scale up curves often are much faster. Whereas something like diarrhea, where essential medicines are purchased by ministries of health, but often by even more diffused local government authorities and the private sector. So that is so much harder to organize demand around a change. And I think that, we've seen much slower uptake, particularly with zinc was introduced in 2004 and still, below 5-10% globally right now. So I think it's much, much lower there. And I think the third factor is just clinical practice. You can have the money, you can have the policy, but if it's not something that clinicians are expecting and want to change, it is much harder to reach these clinicians in a low resource setting than it is, with the AMA here in the US or something where there's very specific ways to roll things out. It's harder and more expensive, quite frankly, to reach a lot of the practitioners.
Great.
I would agree with that, and the two things that I would add are fragmentation and lack of infrastructure. So you mentioned the fragmentation of information, but I think also when you look at the medical communities in a lot of these countries, one of the things that you have is that a lot of physicians, for example, were trained themselves in different medical systems, or they don't necessarily have, our equivalent of the American Medical Association or continuing medical education. So there isn't always a unifying way to roll out information amongst practitioners. And that's at every level, right? Whether you're thinking about technicians or physicians or nursing staff. The fact that it's hard, it's often the case that they're not talking to each other means that you have to do a lot of the work of filling in those gaps. And that brings me to the point about infrastructure, which is when you're thinking about referral networks or you're thinking about trying to make one product, I'm going to be very product focused because that's what I do. When you're trying to get a product, even if it's standard of care, rolled out across a whole country, if you don't have the same, you can have, for example, in a capital city, a really high standard of care, but it's only in that one capital city. So what's appropriate for the capital city is not necessarily appropriate for the area around it. And that disconnect means that scaling even across a country can sometimes be more difficult than scaling to the capital cities all around the world.
Well, that's great, and that's a great segue to this next question of really thinking about, we talk about this in the guide as well, is to achieve sustainable scale, you need to be able to think globally to act locally. So can maybe, Nicole, to sort of build off on your last comment, and then Lena to come in on this. So how do you balance the need for a global vision while also really being able to think about how to come up with a country-specific strategy, and even what country to go to?
So I think just having that idea of thinking globally but acting locally is very important. I think you want to go into the work that you're doing with a global vision, right? You don't want to develop tunnel vision too early on. But that being said, you don't want to be so married to that global vision that you're not able to fail and try again, right? So you don't want to be, for example, when the work we did with Shruti, when we went into India the first time, we're looking at global data, right? So we said, chronic otitis media, which is what we're working on, that's a pediatric disease. So when we went to India, we were looking for pediatric populations to work with. But one of the things that we found really early on is that in India, it's actually much more acute in adults. But there's no way for you to know that until you actually get there. So, even though the device that we had been working on and the thinking we had been doing, and the model we had put together were all done for pediatric populations, the fact that we chose to scale in India first meant that we had to rethink what we were doing. And so I think this component of flexibility, right, and thinking about, okay, how do I be successful in the country that I'm in? But as we're developing this device, we were thinking, okay, right now we're working in adults, but we know eventually this is going to have to be used in pediatric populations. So we need the otoscope, which is the part that basically goes in the patient's ear, to be replaceable, right? It has to be adult size right now. It's going to have to be pediatric size later. And those are the kinds of things that you have to be thinking about so that you don't invest too much money in, one iteration without thinking about what you want to be doing in the long term.
Lita, you want to?
Yeah, and I would agree with pretty much all of that. And when I look at our global vision, I see that as kind of assessing the need. So we have an anesthesia machine that operates without electricity and without compressed oxygen. There's a shortage of electricity in a lot of hospitals, and oxygen is really hard to get to for a lot of these hospitals. And so we knew there was a need for the product, and we saw it on a global scale on several countries. But when I think of the country strategy, it sort of validates that vision and allows us to see whether it's actually something that can be implemented. And so when we go into specific countries, it could be an assessment that there's a need for it, but the demand might be completely different. Who's paying for such a product? What's the price point? What does it cost to get a product into that country, which is very different from country to country? Who are the active players? What is the distribution network in that country? It's impacted everything from our training to our service, to how we sell the product when we go into the country strategy. And it kind of allows us to iterate on our global vision as we kind of pick up this information from a country, on the country level.
Yeah. So, you want to jump in?
Yeah, maybe just to build on that, I think that one of the other key factors in thinking about that country strategy is thinking about a couple countries up front, like I think almost a minimum of 3, or it depends on the size, because the goal is to create a sustainable market, and you want to, to entice businesses to invest in these markets, which are often rural, as you're saying, and difficult to get to. You want to build enough demand that global market is going to be there. And you also want to play the odds. There's a lot of external factors, whether it's a change in the economy. The Nigerian economy has tanked in the last, as you well know, has tanked in the last year and a half. It's really affected over-the-counter medicines there, at least in diarrhea treatment that we've seen, or a change in a political administration. Kenya has had a devolution of government in 2013, where all procurement moved from the central level down to the 47 counties. And so there are factors outside of your control that affect that scale up, and having a few countries allows you to mitigate that risk a bit more.
And I would even add that seeing with multiple countries, you can see what's replicable and what's not. So you start to pick up themes of what can kind of translate to different countries, and then exactly what you need to look for in every country that is going to be very different. So that I really think the multiple countries is really, really important when you go in pretty early on.
Do you have any stories, and any of you have any stories of where you probably picked the wrong country right off the bat? And we're going to get into failures later, but because how do you even think about picking the right countries to start with? Are there any sort of key things that sort of drive this decision making, and where something can really be the sort of test bed to catalyze launch elsewhere?
I think government buy-in. Like you want a large country that has significant demand if you're trying to create a global market. But then you also want government buy-in, because the extent to which the government is invested in scaling this up will really determine what your upward trajectory is.
I would.
Sorry. Go ahead.
I would agree with that, but I would actually broaden it beyond government and say broadly partners, right? So for one of the things that we look for is where do we have the infrastructure and the partners already standing, and how do we capitalize on those? Because I think this will be a theme sort of throughout the panel probably, but the importance of having advocates and having really strong partnerships on the ground who can help take you to scale. That's the most critical thing that a country can have.
Great. So let's switch gears a little bit. Dave did a nice job of walking through our guide. Looks like there's a lot of tools in there. How do you make sense of? I'm going to turn to you and Olayinka and talk about how do you try to sift through all of these different tools? How do you decide sort of what's most important, or how do you get through all of these and determine and prioritize what's most important to do when you're thinking about country, your strategy, setting your strategy?
Okay, so building on what they've said, when you're going into a country, you truly need to understand the country's health system, what's happening at the district level, at the national level, but exactly where are the key players. So in looking at scaling up, you look at what's your end goal. You're looking at service expansion, because what we've seen is mostly pilots. People piloted this intervention in a small place. So how do we get this to everyone? So you are looking at service expansion and sustainability, and how do you marry the two together? There's so many factors in between, starting from your leadership, political will, into a country, if the leadership is not thinking in that line, and you're bringing in an intervention, it's dead on arrival. You look at the barriers, and you'd have to do a situation analysis and also a bottleneck analysis. What's been happening in country? What the projects that have done such an intervention, how have they been able to achieve it? Did they follow the same linear pathway, or another parallel structure was created? You also look at, in prioritizing intervention, key importantly, you look at your stakeholder analysis, and there's a barrier of stakeholders. And if one stakeholder is not thinking along the line, you need to try to immediately address that, because for different people, especially when you're looking at scaling up, you're thinking more of the communities, more of the hard-to-reach places. So you need to get who are the key influencers in this place. You need to prioritize them when you're thinking about scaling up intervention. Then you look at integration. There's no need to create a parallel structure. What's on ground and how can you key into it? Then partnership. You look at, okay, I'm working in MCSP and I'm limited to two states. Where are the other partners working? Because you can't do it all. So you look at the other partners who can support your scale up, and you also look at sustainability. And in sustainability, we look at the data, the indicators, measurements. What's going to tell us we've scaled up at the end of the day? So it has to be inbuilt into your plans at early stages.
Excellent. Anyone else want to jump in on that?
Yeah, I would just jump in really quickly and say part of that is also just mapping out all the points of failure for that one product, from the minute it leaves the warehouse until it hits the hospital, and then what happens afterwards, and then figuring out how to prioritize once you see where the point of failures can be. It could be one step to get a machine into a hospital. The minute that machine breaks, as they all do, you have to be able to find someone who can service it, fix it. And so it really is about identifying all the possible points of failure and figuring out how to prioritize them best.
All right, well, let's talk about failure. And just as an aside, I love this panel because we assigned a couple of them to talk about failure, and everyone said, well, I've got an example too. So it's always great to learn from what hasn't worked. So who wants to jump in? Let's hear some stories about where things haven't worked as well and what you learned from them. Who wants to go first?
I already started with my failure story talking about going to India, so I'll throw it to somebody who hasn't.
I can jump in on that. I mean, one, we have, I think I would say, not quite necessarily a full failure, but we went into Zambia, for example, during a time when their economy wasn't doing so well. The need was clearly there. We had great partners there. It was just kind of this exciting, market for us. And then the economy was not working. The demand was not there as a result. Once the currency crashed, There were also a lot of NGOs that were no longer putting as much money into it, and so we were unable to identify the right demand in the country. And so we saw this need, and so we kind of had to innovate around that and iterate on our model and figure out alternate ways in order to kind of scale up that product in Zambia. But that took probably a 2-year investment into the country before we realized that.
Mm-hmm. And was there sort of a culture of learning around that? Was it something, I know in a corporate environment, failure certainly happens all the time, but was that something where the team worked together to sort of build off that learning? And
Oh, absolutely. I mean, now we kind of know what to look for. We try to know what to look for when we go into different countries, and we kind of, it's again, figuring out different points of failures that we had not identified early on, and kind of figuring out exactly at what point to iterate on our model in that country.
Olayinka, you want to give us an example?
Okay, I wouldn't say it in terms of failure, but I'll look at it at first attempt in learning. That's what so we're already planning for failure, but in terms of we're going to use it as iterative learning. So for us, we're working on scaling up cloxidine, an antiseptic gel for umbilical cord care, and it's been a long journey since like 2012 that we've been working on this. So our first sign of failure, which will make us learn, was looking at the metrics. Early on into our discussion on scaling up this intervention, we didn't align or build in our metrics on time. That means the data to capture the cloxidine use. Discussions have started in country on looking at, making sure the health management information system does have something to track cloxidine use. And we're also looking forward thinking or forward failure and looking at setting up interactive learning whereby we sit down quarterly or biannually to review what we've done so that we can adapt to changes immediately and not wait for 2 years, 5 years, or till the demographic health survey comes to tell us, oh, you're still not doing anything in newborn health. But we're thinking ahead. Mm-hmm. So part of the support MCSP is giving the country, it's thinking forward. Interactive learning is being embedded in what we're doing with scaling up cloxidine. So it's not failure per se, but we're forward thinking and anticipating the failure. And also in anticipating the failure, we look at the healthcare workers. They're a big chunk of resistance, but they're also looking at how to address such gaps. And for us, the policy document, the launch of the cloxidine strategy document, has somewhat, it's going to somewhat minimize this effect because it's not a policy in country. So as a health practitioner, you have no choice but to adapt, go with the government policy on this.
And this, I'll add that the national strategy, which you all just released in Nigeria, our team, as they were developing this guide, actually built the guide while also working in country on the national scale-up strategy for chlorhexidine as a way to sort of ground these tools in some very sort of practical examples and realities, and it was sort of one of the ways we sort of pressure tested even what we were thinking.
I love that idea of failing forward, though. I think that's I think that speaks a lot to the kind of attitude that you have to have in these situations, because that's certainly what happened to us, right? Was we found out we were looking at the wrong population, but then in the end, what we ended up finding is that, well, adults are great surgical candidates, right? And so we make surgical products, and that was a business model that wasn't previously open when we were looking at pediatric populations who are not usually clinically indicated for surgery. So you can find yourself in a position where a failure actually opens up new avenues for growth.
Yeah. Great. Did you want to add any failure stories while we're to revealing all the truths here?
Yeah, no, so one of the countries that Chai's been working on scale-up of diarrhea treatment with children is Uganda, and we started the program there around 2012. And the last measurement of that was the 2011 DHS, and ORS usage had been 44% at the time. So 44% of children with diarrhea in 2011 in Uganda received ORS. Starting in 2013, we didn't do a new baseline. There wasn't evidence that it had moved much. And so we spent 2.5 years really working in the public sector and the private sector, bringing a co-pack of zinc and ORS, and had this huge full court press with government and partners on scaling it up. And we measured it in 2015, and it was at 35%. It had gone down. So it was incredibly frustrating. And of course, that did lead to a lot of self-reflection on why that was. And part of it was we went back and figured out that the market had been flooded through the public sector in 2011. It was a push system in the government. They'd been oversupplying all the public health facilities with ORS, and it had spilled out into the private sector. So the private sector was sort of wiped out. And this is a common problem in global health, where you have a distortionary infusion of product that wipes out your private sector market because prices were down because the public sector is just giving it on the sly to selling it then in the private sector. So that was one factor, was it was inflated, and we had no idea about that and really understand the historic market trends. And then the other factor that happened is we worked with the government to introduce a co-pack. They were so excited about it that they signed a tender for a co-pack that was more expensive than the single units were. And therefore, and they had a fixed budget. So then the government was putting in less product than they had been sort of 6 months before this co-pack. So it did lead to, certainly reflection around understanding what your historic trends are if your baseline may be inflated, but then also not rushing to move to a new product. In all the other countries, we were able to get the price of the co-pack below single units combined, but they hadn't done the necessary sort of negotiation on that to get to that point. But I think it is really hard, and we have to be honest in the global health community to run to criticism or profile our failures, because a lot of our organizations are project-based. And so, you always want to showcase your successes to get your next, to work on further work. And I think it's really important as a community, and particularly with donors, that we ask for mistakes and highlight them. And I actually think it's been interesting with the Gates Foundation, who's one of the partners we work with. They're constantly asking us about mistakes, and we have to write about them in reports and present to them on mistakes. And it's a good practice to get in.
Right, and I certainly think that we need the big government donors to be doing that as well, and we need to be, I think, recognizing that there is room to first of all, we know this process isn't linear, and some things don't work, and you need to be able to go back, you need to be able to pivot, and you need to be able to reflect on what's not working and why, because we're not going to get better if we don't do that. And so creating that space for that dialogue and for that learning, I think, is truly critical. So I'm going to open this up and let all of you into this conversation. I already see one hand. We might have mics that can go around the room. But please do, we have a great panelists here, so please do jump in and ask away.
Hello, thank you for the panel. My name is Fabio Castaño. I work with Management Sciences for Health. And scaling up, one of the key elements is actually financial resources and cost management. And I think Kay mentioned a little bit about that. So who's paying for these innovations? And how to balance out-of-pocket expenses with market segmentation, with benefiting everybody, especially the most in need. So how do you see domestic investments and the private sector helping in that regard?
Okay, great question, and a lot in there. Does anyone want to, and it also depends a lot on what kind of products we're talking about too, but anyone want to jump in that based on your own perspective? And Lane?
First part of the question, who's buying the products, our customer base is quite diverse. We have ministries buying it, individual hospitals, individuals who are visiting those hospitals, large NGOs are also buying it. So there's that becomes a challenge of who's buying it and figuring out kind of their procurement methods, what the best pricing is, what's the right pricing for the product. And we found certain ways where the private sector can get involved. We've actually have a few countries that have a subsidy model. And so what that creates is a cheaper price, a lower price for the customer, but it's not a donated piece of equipment either. We want to make sure hospitals have buy-in, that that's the product that they want, but it's able to, it makes it a price that's affordable to the hospital in order for them to purchase their own equipment. And so kind of we think of them as a really good partner sort of to innovate around different pricing models in different countries.
Okay, let me chip in. So looking at it in scaling up, you're looking at either a commodity or a device. In terms of commodity, you look at what's the target audience. If you're trying to scale up something like misoprostol for postpartum hemorrhage, it's mostly the facilities that are supposed to provide that. If you're looking at chlorhexidine for the prevention of neonatal sepsis, it's more like a product that is part of your delivery kit. So, and you look at who's currently paying for what's being used. If you're looking for us in Nigeria, the chlorhexidine is trying to replace an existing market. We've not been practicing dry cut care, but we've been using alcohol for cut care. So as it is, people are currently buying something for cut care. So you're doing more of like a behavioral change. And because it's also a new product, you also try to look at, can governments procure? Can you also get donors to buy in? But the end result is an over-the-counter drug, and it should be readily available to any woman going for delivery. So in terms of financing, for some commodities to have to be out-of-pocket payments, depending on, to be out-of-pocket payment. Then you also look at, for us, for some commodities also, you look at local production. Chlorhexidine is readily available, and it's a simple gel, so getting in-country production also makes the cost a little lower than importing such products. So for different commodities, depending on the innovation or intervention you're talking about, it varies. Mm-hmm. Government can procure, individuals can procure, donors can procure. Mm-hmm. So it varies. It's not a one-cap-fits-all. Yeah.
And I do think you want to think about in the introduction, what is the price reasonable for the market in this country? I mean, you may have a product that is too high priced for the market that you're targeting. I think there's a couple areas like vaccines and ARVs where you have these, long-term financing through global mechanisms like Global Fund or PEPFAR or Gavi. But in the most part, it's your domestic resources, and that's right. It should be, like they're the ones that are responsible on the long-term basis. And so I think that analysis on the back end needs to be done before you're going into those markets to make sure in the long run that works. And in my experience, it often, the resources can be there. In many cases, you're substituting an existing product, so it may not be more expensive, or you're trying like an anesthesia machine or oxygen concentrators or something. They're actually buying those now. Individuals, hospitals are going out and they're breaking down within 2 years and they're having to buy it again. It's all this fragmented purchasing, and so you can actually spend a lot less if you consolidate it more and do it in a more effective way. But it's a great question.
Yep. We have another question up right here.
Thank you for a very interesting panel. I'm Susan Geely with the Maternal Child Survival Project. A question about equity, that often donor-funded projects really place an emphasis on equity, because scaling up, sometimes it's easier to reach more people in places where people are already being reached. So just how do you deal with that in your scaling up?
Equity, who wants to take that up?
I know, we're just getting some very interesting data back from our India program, where we've been working on diarrhea treatment in 3 states the last couple of years. Our focus has been, the children who die of diarrhea are dying in the rural areas. So the program has been focused on rural areas, and what we've tried to do, and actually worked with FHI 360 and other partners have been doing this even before CHI got in, so we're not the only partner doing this, but really bringing the pharmaceutical detailing model to rural markets. Because most pharma companies, the way, detailing is a proven tactic. It works. But that, in India, for example, it happens in urban and peri-urban areas. These rural, informal, they're called rural medical providers. That's where 80% of the care is sought in rural areas. and information trickles to them. They have no information that's directly given. So we did rural detailing and also product placement in villages using local entrepreneurs. So not provide short-term financing, but then that wound down and they continued to do it. And what's been really interesting now, after 4.5 years, we've just gotten some data back, and we've looked at the usage of ORS and zinc in the wealthiest quintiles and the poorest quintiles, and that gap has gone down fourfold. So there's still a gap of 20% between the wealthiest and the poorest, but it's gone down quite a bit. And then we also look at it between rural and urban. Like, what does ORS and zinc coverage look like in the urban area? What does it look like in the rural area? And you're trying to close that gap. So that's how we measure it. And I think it's really important because obviously it's easier to reach urban and peri-urban areas. But we've got to think about, and I think a lot of the questions now too are, who are the kids that are dying? The kids that are dying are probably the most vulnerable in that poorest population. And so, I mean, there's a whole avenue you can go down around the equity piece that's, I think, very interesting.
Okay. Other questions? We've got one in the back of the room.
Thanks, ladies. That was a very, very welcomed conversation. I'm Lisa Hedman. I'm from the World Health Organization in Geneva. I'm very grateful that the timing worked for me to be here. One of the things that when we think about launching products, and I know that a lot of our global leaders like to come to us in meetings and talk about how change is disruptive and it has to do all of these things. But just thinking a little bit about the plans that we put in place, I didn't hear a lot of discussion about regulatory affairs, but I know everybody's aware that that's a big part of what needs to happen. But it seems to me that in a lot of these places are a lot of the products that we're talking about interfering with a healthcare system, we're talking about changing practice, we're talking about introducing products that are going to be used on people, and in some cases very vulnerable people, the most vulnerable of the vulnerable, the little kids, for example. But what's our plan B? When we go in and we do a launch and we find that something doesn't work, in some cases, some of the situations that we've seen recently have been actually, I think the chlorhexidine one is a difficult one. We've seen a number of other products that have gone out and they haven't had the results that we wanted, but in some cases they've had negative results. So as we make these launches, are we actually investing in plan B as part of our plan, or are we waiting and are we reacting? Thanks.
Anyone want to tackle that?
Well, I mean, I guess I would say it depends why Plan A failed. When I at least listened to that, that's what I would say. Like, I think if there's something where the product is not being used or it's not user-friendly, or I think there is something where a step needs to be taken back to see if the product is a good product. I mean, just like any other business, assessing whether a product is actually a good product is really important. If Plan A failed because of, other market mechanisms or things that you can try in another country, I think then, yeah, Plan B should be put in place. At least what I found in my experience is that you can't figure out Plan B until you know what happened with Plan A. And to plan in advance becomes kind of this exercise that's not really very productive. But once we can assess what's happening in Plan A and what didn't work, it's easier to iterate and do the trial and error and go through the trial and error process.
Yeah, we often talk a lot about a right product for the right market at the right time, and I think that's sort of summing up of a lot of what you said. And I think even there was questions you talked about ORS and zinc. I mean, here you've got something where you would expect to be able to sustain these gains and really being able to go back and evaluate that. And then some people have even said, is that the right product, or we need to do more innovation around the product itself to get more uptake, but you were able to go in and unpack that and really better understand what was going on, which I think is a really important step to probably figure out what that plan B should actually be.
I also think it speaks to the importance of piloting and the importance of testing on a small scale before you start talking about scale, right? The conversation that we're having today is about how you bring something that's already successful to scale, but I think that's one of the reasons that you do want to be thinking about how you are going to iterate and how you're going to fail on a local level before you start disrupting countries or health systems on a large scale.
All right, 2 questions over here. Go ahead. You go first.
Hi, thanks. I'm Monica Kerrigan. Great panel. I wanted to actually explore before, and you all had mentioned it a little bit about measurements and metrics. And I think one of the reasons that the private sector has done so well in terms of coverage and penetration is because they expect people to measure. And what have you learned in any sharings that you could, or best practices on the new approaches to measurement and how it's transformed some of the service delivery places or spaces that you're working in? Thank you.
Great. And why don't we get this second question, too, just so we get both of them on the table.
Hi, I'm Alex Reinhart with Vive Healthcare, and I lead our HIV prevention effort for the company. And we are developing the first long-acting injectable antiretroviral for both HIV treatment and prevention, and we're in phase 3 with that right now. And the question that I wanted to ask, which relates to the last comment that you made, was about the steps before scale-up. So I would love to hear about your experiences, failures, successes, advice on doing demonstration projects, pilot studies, and making that runway up to scale-up an efficient one.
Okay, and then let's, we've got one more up here. Avery, come back up. Let's get that one on the table just because I want to make sure we get all the questions out.
Hi, I'm Priyanka from FHI 360. I'm curious to know some of the incentivization models that you guys have utilized in terms of to ensure uptake and scale, right? So I think it's, yes, product can speak for yourself, but I'm sure there's some other incentives that you provide. So I'd love to hear more about that as well.
Excellent. Okay, so we have 3 questions. So one around best practices around measurement, steps before scales, or how do we actually test and get something to proof of concept and know that it actually works, not just in one community, but you can actually sort of test the scalability of an idea before you actually go to scale. And then the third around incentives around uptake. So if you each can, you don't have to answer all 3, but if you want to answer any one of them, we'll kind of go down the road. Who wants to take one?
I would love to answer the incentives question,
okay,
if I can go out of order. That's actually a bbig part of our model. We actually try and make sure the incentives are in place prior to kind of really building out the model. We rely heavily on distributors who are really great, and it takes a long time to get to know them and understand their business, and everything from picking a distributor to working them is really about incentives and understanding what motivates them, but also going down to the hospital level, understanding the work of the clinicians, the nurse anesthetists in this case, the clinical officers, but also understanding who's purchasing at the hospital, who's making the decisions at the hospital, which is very often, almost always, someone different from the user. But our entire model, which is really focused on service and training, is really built around making sure our partners are also incentivized, and a good product is actually not going to be enough to get, through the full distribution chain and get through service and training. And so we make sure everyone along the way is incentivized. And I would say we spend the bulk of our time in every country focusing on that and building the infrastructure to support the machine before placing machines in a country.
That's great. So you can answer anything. You can add to incentives or go to measurement and testing for scale.
Okay, so when you're looking at piloting, that's what you do before scaling up. So it's one of the key things you need to look at is integration. What's currently happening? What if you're looking at you're talking about HIV? What's the country currently doing in terms of HIV? You need to take a sample of the country, look at target the key, maybe the highest burden state or region that has the highest incidence of your target audience. Then you also need to get the stakeholders involved at an early stage. We're talking of low resource settings, low income countries, I believe. So you also need to get the key stakeholders involved at an early stage. You need to ensure that what you're bringing in, it's policy alignment, stakeholders engagement, and also identifying your data, whatever you want to collect at the end of the day, should be in keeping with what exactly is happening. Do not create parallel structures, but go with the flow, more like go with the flow. It's the easiest way to pilot things. but also identifying the barriers or failures from the present intervention or innovation, and trying to address those barriers and challenges.
Great.
I'd love to jump on this question of incentives, if only because you said it's something that the private sector is so good at. But I would say it's something that you have to think really broadly about when you're thinking about incentives, right? In the private sector, you think about employee incentives, but you also have to think about clinician incentives and be really careful with how you're engaging those, because part of it's around ethics, but part of it is also around efficiency, right? So going back to this theme of failures, one of the things that we found in not the specific program I've been talking about, but in our work more broadly, is that one of the reasons that patients don't make it to tertiary care is because physician incentives can be skewed. And so we have, for example, a heart failure program where we found a lot of physicians were trying to treat with drugs when in fact their patients needed devices. But because the physicians weren't trained to put in devices, in order to retain the patient and their business, they wouldn't hand them off to someone who could put a device in. Now you can say certainly as a device company, we have a vested interest in that, right? But that's where you can get alignment, right? Where you can say for the good of the patient, right? We can't make the diagnosis, right? We can't tell the physician what they should be doing with a patient, but we can say product agnostic, whether you're buying our stents or somebody else's stents, here's a training that we can provide about how to recognize a patient who needs stents. And all that is to say, going back to this groundwork that you need to lay, going back to incentives, cast your net broadly and be thinking about all the different groups of people, stakeholders who are going to interact with your product or going to interact with your ecosystem, right? We talk about ecosystems a lot, and that's something that you have to think about is who are your natural partners and who are perhaps not your natural partners that you need to think about how to find common ground with them. So I would say, I guess in some, incentives is something that's much broader than your own staff or your distributors. It's something that everyone who touches your product or your pipeline of care are going to have to, you're going to have to consider each one of them.
Great. And anyone have any insights around measurement? Any new nuggets to share? Super quick.
Yeah, I think the key on measurement is that it's an outcome measurement, that it's based on patient usage of your product, because otherwise, availability, track availability, track provider knowledge and consumer knowledge, but those aren't, there's a huge gap for providers between knowledge and actual practice. And so what matters is the practice and what the patient is taking at the end of the day. I think it makes it very hard for spaces like pneumonia that many folks may know about, where there isn't a standard globally accepted norm on how do we measure that children with pneumonia are getting the recommended treatment, because that is what you need to measure, and we should hold at scale, not in a few little communities. But I think we need to hold ourselves all accountable to that.
Great. Well, just to wrap up, I've asked our panelists to share some words of wisdom, and since we live in the age of Twitter, and Twitter seems to be getting more and more popular by various individuals moving to town. So give us some key insights or advice for practitioners who are looking to launch and scale global health innovations. And let's give your 140-character quick soundbite snippet.
I confess I wrote mine down. I just said look for opportunity in everyone you meet. People are your best opportunities, and you never know who's going to help you along the way.
Excellent.
I'd say plan thoroughly, but move to implementation urgently. I think we overplan too often. We don't know what we don't know. Just go for it.
Yeah, I would kind of build on that with the kind of just do it sort of model, where you learn the most from actually implementing and doing.
I would say make it simple and smart integration.
Simple and smart integration. Excellent. All right, well, with that, please join me in thanking our panel, thanking Aspen Institute and our team.